All right.
All right. Do you hear me clearly also?
So we hear you clear, sir, loud and clear. So good evening, everybody. Welcome to ISOMT's free live lecture on hip and groin pain in athletes. We welcome Dr. Ufuk Degirmenci. I'm sorry if I'm pronouncing your last name correct. So he's a sports medicine physician by Istanbul, Turkey. I welcome all to our free live lecture on hip and groin pain in athletes. It's a very common debilitating condition which can be very frustrating for an athlete, whether it's a basketball, soccer, court, or a field event. So athletes can have a lot of groin and hip issues, whether it's a male or a female. We will discuss about certain areas. Dr. Ufuk is a sports medicine physician who is currently practicing in Istanbul, Turkey. He has practiced with a lot of sports organizations. I am Dr. Parijat Kumar. I am the founder of International Sports and Orthopedic Manual Therapy. I am a certified spine and sports specialist too from the USA. And I welcome you all again to our free live lecture. This lecture will be recorded. So if in case you guys want the certificates or the video recordings of the lecture today, you're welcome to go on our website and look for our premium membership if that's okay for you. All right. So without wasting much time, Dr. Ufuk, I give the dice to you and it's all yours. Good luck. Take it.
Hello, my friends. Thank you very much, Dr. Parijat, for your invitation me to this good, informative lecture, hip and groin pain in athletes. I'm Dr. Ufuk from Istanbul, Turkey. I'm studying, working with elite athletes also. We see athletes, both male and female, with complaints in this area. And also it's a super confusing area, you know, we have lots of potential diagnoses. And so what I'm going to try to do today is hopefully break this reasonable, simplified and anatomical, primarily simplified approach for our athletes' pain and our diagnose our outcomes. Thank you very much. And I'm starting my presentation. But yes, today we learn between you list potential causes and different entities of hip and groin pain in athletes. And also we describe the categories outlined in Doha Agreement. I will talk about later in this lecture also, November 2014. And diagnostic tests used to diagnose hip and groin pain in athletes also, and rehabilitation program to treat athletes we will look. Also, why hip and groin is important. My friend, we have athletes and they are very busy man. They have to work and they have to play. We have in this position, our athletes have significant time loss with groin and hip pain. This is the most important thing for us. Hip and groin pain is the third most significant time loss cause of our athletes. Okay, one is, for example, ankle injuries. If you play with soccer players, I'm working with soccer players a lot. First of all, ankle injuries is most time loss. Second one, knee and hamstring injuries. And third one is this, hip and groin injuries. And in the hip and groin, you know, we have explosive multiplayer movement in single stance. You know, we are working with athletes. They have movement and explosive movement. And with single stance, they are jumping, they are sprinting, also they are doing lots of high-speed change of direction. We know this, and it makes the different difficulties of hip and groin area. If while you are changing your direction, hip and groin has lots of difficulties. Also, why hip and groin pain is difficult to solve? One, this is from complex anatomy. Lots of potential diagnosis. I said to you, there are multistructural injuries in this area also. Also, terminology and classification system. Yes, going on. I told you about Doha Agreement meeting on terminology and definition, because we have to make clear terminology. We are working together. We are physicians, physiotherapists, our athletes, our masseurs. Also, we have coaches, we have team managers. We have to talk the same language. It's very important in this area. If you are dealing with athletes, you have lots of problems. One of them is speaking same language. You have to be clear and you have to say the same language with your friends, also with your teammates and coach, also with your managers. In the Doha Agreement meeting, there was a terminology and definition in groin pain in athletes. How can we do this? How can we how can we determinations and definition? How can we do it? We do it with defined clinic entities. It's about anatomical. First of all, adductor-related groin pain. We know adductor longus and adductor muscles in here, and iliopsoas muscle in here also. Second one in iliopsoas related groin pain. Third one is inguinal related groin pain, and fourth one is pubic related groin pain. These are the entities, and the other one is hip related groin pain, and the last one is the important part is other causes of groin pain also. Yes, we spoke about this, and I said to you entities defined during meeting: adductor, iliopsoas, inguinal, pubic, hip, and the other musculoskeletal causes. We have to know the other ones also. Some of them are most important in this area. I will talk about also, but now I will tell you, if you have a young athletes and young players, you have to be careful with apophysitis, avulsion fractures. You have to be careful with stress fractures, femur neck stress fractures. You have to be careful with, if you have women athletes, you have to be careful gynecological conditions and tumors. If you have an athlete, you have to be careful for testicular tumors and the other tumors also. Also, we know about referred pain, and in ISOMT cohorts, we talk about a lot in this area. You have to know referred pain also a lot. Okay, we go on. We go to Perholming study that they did in 2007, and long-standing groin pain. They talk about long-standing groin pain, and the entity of approach, they made extension, and they made this extension pain in the affected region. Also, we have to know acute or long-standing. What is long-standing for groin pain? Long-standing means up to 2 months. If you have pain up to 2 months, we said to this, we have to say this pain long-standing. If it's under 2 months, it's acute also. We have to do clinical diagnose. We are doing clinical diagnose. No imaging required. We have to make clinical entity approach, okay? Why are we doing this? We will talk about this. First of all, I want to talk about anatomy. Here is the femoral triangle, you know, femoral vein, artery, nerve, adductor longus muscle, sartorius. We will talk about adductor longus a lot in this lecture. Maybe I want to show you lateral part also. And this part of my presentation, I want to tell you about adductor longus. You know, it starts from, you know, for main actions adduction for the hips, and it starts from body of pubis, inferior to the pubic crest, okay? Adductor brevis, adductor longus, and adductor magnus. Gracilis also attached to the pubis. We know this. Pectineus also attached to the pubis also. And the other muscle, the big muscle, iliopsoas muscle, we know its origin and insertion. We know the origin T12 till L5. And distal attachment, lesser trochanter of femur. Also, we have to know lumbar 1 to 3 innervations. Okay, I'm going on the pubic ramus. Pubic ramus is the most important place in this area. We have to know rectus sheaths. Rectus abdominis attached to the pubic bone upper part, and adductor longus tendon and muscle, the second one attached pubic bone also. Gracilis we talked about, and the pubic body you see here. Pubic symphysis is a cartilaginous place, and you see conjoint tendon also 7 part in here, transversus abdominis and internal oblique muscle tendon. An arc of external inguinal ring you see here. Spermatic cord 8 is here, and the 9-1 is inguinal canal also. I want to talk about red flags. Before start to my presentation, red flags are very important. Also, very important. We have to talk about our athletes' history of cancer before, also other red flags. We know night pain is more important thing in this area. If our athlete has night pain, we have to be careful. If he or she has fever, history of trauma, unexplained weight loss, painful urination, we have to be careful. Prolonged corticosteroid use, you know about what? We know it from stress fractures, avulsion fractures, avulsion problems. Okay, we talked about our terminology. Nowadays, we don't use these terminology, okay? No use adductor tendinopathy, no use athletic groin pain, no use Gilmore's groin, sports groin also. We are using adductor-related pain, also inguinal-related pain, iliopsoas-related pain, or pubic-related pain only. These are not our terminology, okay? We don't use osteitis pubis nowadays. We say pubic-related pain. Athlete has pubic-related pain, okay? So, I want to talk about epidemiology. I want to be fast also. I said to you, third most common time-consuming injuries in soccer players, hip and groin injuries, 14% in a season we see, and all of the injuries, most we see adductor-related injury in this area. 60% of the injuries of hip and groin area is adductor-related injury. We see in this article match play incidence is more than training play incidence also, because you know match playing is more, you have to afford it. You have to make more effort in the match play also. Also, training and match play, same article I show you in this. And other sports, I see lots of soccer players, I said, and the articles are, in the most of the articles, we see in soccer players, okay? But other sports, lacrosse, cricket, basketball, and rugby, we see also hip and groin injuries. And 5% of all injuries in baseball, also groin and hip injuries. Yes, I want to talk about characteristic of groin injuries. Groin injuries is nearly 70% gradual onset, 60% nearly dominant side. Which side is dominant? Injury is in the dominant side also. And 6% is bilateral. Highest incidence in early season. We see all of the highest incidence of injuries in the early season also. Also, I can say nearly 90% of these problem single entity. only adductor related, not multifactorial. In this study, Mosler and friends, and they made a 2-year prospective study with 17 clubs, 600 players, and they said single entity is the most one. And I can say you 17% of minimal severity, you see it. For the multiple entity case, there were no cases. Oops, I'm sorry. I want to see. Oops. You see, if our athlete has multiple entity, the problem severity is going up. You see it, 54%. If multiple entity, our problem is more, okay? Also, I want to say you categorization of groin injuries, 70% nearly adductor related. I said to you before, you see it hip 1%. You see other 3%. You see 9 pubic, 12 iliopsoas. Because our athlete, we are working with athletes. Athletes have adductor problem most. Okay, I want to talk about history of the pain. I want to talk about location of the pain. Is very important for learning the location of the pain. Where is the pain? We want to know the location. I'm sorry. Location is the most important place in this. I want to say you. I'm sorry. Do you hear me also, Dr. Parijat? Dr.
Yeah,
Parijat.
we can hear you. We can hear you, sir.
Okay, thank you very much. The location of the pain, the precise location of the pain should be identified if it is possible. Groin pain that is felt anteriorly in the mid portion of thigh suggests pathology related to the iliopsoas, you know. If you have a pain in the mid portion of the thigh, we can say it from the iliopsoas related. Pain located more the medial side of the groin, we said adductor related cause of the pain, okay? Pain in the groin, in the buttock, and the buttock could be indication of the hip joint. If you have a pain in the groin, also at the posterior, at the buttock, could be indication of hip joint involvement. Posterior buttock pain without groin pain is more an indication of low back pain, low back problem. We know it. We spoke about it also. Stress fractures are rare, but the possibility of the stress fracture of the femoral neck and pubic bone should be considered in this way. We have to know the location of the pain, anteriorly, medially, posterior, or we have to know all of the area, okay? And the second one, injury mechanism. We have to know the injury mechanism. Was a high force involved? Was it a subtler incident? Was a sound like snapping, clicking, or sensation felt in the athlete has or has not sensation of heard about clicking, or could the player continue on the pitch? It's important also for us. And third one is training history. Training history is important because if no acute incident can be recalled, the activities preceding the injury and the development of symptoms can sometimes be very helpful. Was the load of activities increased? We have to ask our athlete or patient, was the load of activities increased? Was the player running longer distances or lifting heavier weights or learning new techniques? Any change of equipment, surface, and technique, we have to ask and learn it. Any previous problems? During which activities does it hurt? We have to ask it. Which activities does it hurt you? And what alleviates the pain? How is your pain? And we spoke about systemic symptoms, red flags, some of them. accompanying weight loss, fatigue, fever, or a history of recent infection, maybe diarrhea, maybe reactive, because that could reflect reactive synovitis in the hip joint, bacterial infection in hip joint, or a malign condition. We have to think about this. And night pain, I said to you also. Some of the risk factor we have to learn about: athlete, type of sport, which sport are you playing, level, which level are you in, professional, semi-professional, or before season, end of the season, and also the expectation is important also for us. In treatment, while you are doing treatment, you have to learn the expectation of the athlete. Is there any match 1 month, 1 week after? Maybe championship match there will be, and athletes want to play in the championship match also. But we have to know the expectation of the athlete, and the time of the injury we have to know, time when the injury happened, and past injuries, illnesses, operations. His family histories is important also. Maybe some autoimmune conditions. Athlete has some autoimmune conditions. Also, we have to know sport-specific movement, sprinting, change direction, kicking. These are all related to the problem of groin and hip area also. Also, I want to start to examination, and I want to make these examination with clinical entity. I want to call my patient. A minute, please. Mr. Shapak, can you come, please? Okay, I want to talk to you about examination now. I have a patient. Do you see me clearly? Yes. Is this better? Yes, this is better. Is it good for us? Dr. Parijat, is it good
That's
for
good,
us?
sir. That's good. That's good.
I have an athlete near me. I want to make an examination for him also. First of all, if I have an athlete with hip and groin pain, I start with seeing the part of walking. First of all, I want to see inspection with walking. How is walking? Is there any problem with walking? Is there any problem with going and coming? Go and come, please walk, please. Come to me, please. Yes, is there any pain? Is there any problem? Yeah. No. Okay. Second, in groin and hip area, we have to look for the level of the lumbar part, pelvis level. I'm looking for the level, and is there any differences between the right and the left part? And second one, I want my athlete to take his leg up, and I see for the muscles, this is Trendelenburg sign, you know, take the leg up and look for any weaknesses of gluteal muscles. If there is weakness in the part of, if there is weakness and going down, the other part of the lumbar area is weak, gluteal part. We are looking for the gluteals also. Also, we are looking for an athlete for single stance hop test. We are using single stance hop. What is, we want from our athlete to make a hop. And can you make a hop, please? With single foot. Yes, one more time, please. Is there any painful? No. No. We are looking for the any if our athlete has acute pain and he's say with hopping pain is going up, we have to we have to be careful about stress fractures of femur. We have to be careful about femur stress fractures, femur problems. So we want to start for examination also at the bed. Please lay down, please. Yes. In laying down, we make inspection for our athlete for the level of splenic anterior superior levels at the both part and looking for any problems. And the second part, we start for palpation. Palpation is the most important part of these problems, hip and groin pain problems. We start for palpation. For example, first of all,
Dr. Ufuk, I'm sorry to interrupt. Dr. Ufuk, do you mind stop sharing your presentation so that the people can see the demonstration in like a bigger window, please? Just stop sharing your presentation, please.
Oops.
It says stop share.
Yes.
Thank you. That's much better. Thank you, sir.
Is it good also? You see me? I don't see you also.
We see you big. Don't worry. We see you big. Thank you so much.
First of all, we start with, if our athlete is young, we start with anterior superior iliac spine palpation. Anterior iliac spine, can you see me? Because I don't see my image.
We can see you. Don't worry. We can see you clear, crystal clear. We can see you.
We are looking for anterior superior iliac spine for the sartorius attachment. If is there any pain, we are thinking about apophysitis of this area. Second one is anterior inferior iliac spine for the rectus femoris attachment. We are looking, is there any pain in this area? No. Second part, we are looking also, yes, is there any pain in here? No. In the second part, we are looking for pubic symphysis. Is there any pain in the pubic symphysis area? No. In this part, right and left part also. We are looking for iliopsoas also. You know, iliopsoas is a deep muscle between splenic anterior superior pubic symphysis. You can make some big pressure for the, yes, yes. Take your head up, please. Head up, please. Yes, yes. Go down. Is there any painful in this area? No. Yes, we look for the also iliopsoas, but I want to start with adductor-related groin pain. Okay, I want to look for the adductors, local tenderness of adductors. Pubic symphysis, we know down the pubic symphysis, we have adductor longus muscle attachments. And this is the most problematic area for our athletes. I am looking for local tenderness, also adductor muscle. Is there painful? No. And I'm doing some little bit external rotation and make some, yes, make some relaxation for the muscle also. Is there any pain? And I can put my leg under the leg also and looking for one more time. Is there any pain? No pain. Yes, I'm looking for the pain, local tenderness for the adductor related groin pain. And the second one is pain on resistance adduction testing. I'm looking for resistance adduction. Please push my hand, push. Is there any pain? Is there any pain? Yes. No pain. Yes. In our athletes, we have no local tenderness of adductors, no pain on resistance adduction test and resistant adduction test. We can use also in resistant adduction test for outer range. If you are working with an athlete, you have to look for outer range because outer range may be more painful for our athletes. Please push my hand. Please push my hand. Is there any pain? No pain. Okay. We look for adductor-related groin pain, and he has no pain at the adductor area. Second one is we know iliopsoas-related groin pain. We said from clinic entity. I'm going from clinic entity. Okay. Second one, iliopsoas-related pain. We are looking iliopsoas. I said from here, ASIS, pubic symphysis. Between them, we are looking any tenderness at here. Is there any painful? Is there any pain? A little bit pain, he said. Okay, also we are looking for iliopsoas groin pain for resisted hip flexion. Pain on resisted hip flexion. I am looking at this position. Please push my hand. Push. Resisted hip. I am doing resisted hip flexion. Is there pain? No pain. He has no pain also. And the third test for the iliopsoas, we know Thomas test, pain on hip flexor stretching. How can we do it? We have to take our athlete down off the table. Come on, please. Take your this. Come down, please. Come down. Little down. Come. Okay. Yes, take this. Bend your knee, take in, and we are looking for the tenderness of hip flexors. If there is tenderness, always this leg go ups, and we have the athlete has pain in this position. If we make a little bit stretch, there will be a pain. It will be painful. Do you have any pain? No. Yes, we saw no iliopsoas related groin pain. So we are looking for the third one, the entity of the third, pain in the inguinal canal region. Please come up, please. We know inguinal canal starts from anterior superior iliac spine to pubic symphysis. And we have to look for any tenderness from, here is the ASIS, you see me also, here is the ASIS, and here is the pubic symphysis. We are looking for any, but no force, much force, little bit force. Yes, is there any pain? Is there any pain? Is there any pain? No inguinal canal region pain. Tenderness no tenderness also. Also, we are looking for inguinal hernia for the athlete. If we, but we have to look for standing. If we want to look for inguinal hernia with standing, also we made some maneuvers. Valsalva, cough, sneeze. We want our athlete to sneeze. Sometimes we can do it with lying also. I am doing from the testicular area, near the testicular area, external inguinal ring. I am looking. Please cough. Cough one more time, please. If you feel any hernia, palpable hernia, this is not inguinal related groin pain. This is other causes of the groin pain. Okay, we don't want any pain in this position, or we don't look for the true hernia. Okay, the third.
Dr. Ufuk, if you don't mind, can I add something to that, please?
Okay.
All right. So, guys, Dr. Ufuk is talking about the inguinal thing, and these are the differential diagnoses of the hip and the groin pain. Okay, he was discussing about different muscular tests like the Faber test, which can be used for iliopsoas. He was using Thomas test, which can be used for the rectus femoris. Now, if you allow me 1 minute, Dr. Ufuk, I would like to talk the differential diagnosis of the hip or the groin pain, where you, and I will share an article by Dr. Cameron McDonald. He sent me that, and Steve Short, he's the sports physio of the Denver Nuggets, which is a basketball team in the USA. So they both have kind of done this, written this article on the hip and the groin pain in elite athletes, especially the basketball players. So inguinal canal, when Dr. Ufuk was telling, I would like to know my learned participants over there that first of all, you need to kind of differentially diagnose the hip and the groin pain, whether it is a bony problem, whether it is an intra-articular problem, or whether it is a musculoskeletal problem. Intra-articular can be labral pathologies, can be a loose body, or can be other soft tissue inside the joint. Intra-articular. Bony can be your femoral head, your femoral neck, your acetabulum, etc. Okay. And then, yeah, sorry, go ahead.
I want to talk about hip problems second way, because the most part, first adductor, inguinal, iliopsoas, and pubic, and the second part, hip is little bit a 3% for us. Maybe I will talk about examination in the second. Can we go on and you will?
Inguinal, I just want to mention about the inguinal canal that you were talking, Dr. Ufuk. inguinal canal, if people want to kind of see, because the inguinal canal anatomy, I mean, I have a picture over there. So your inguinal canal is, if you see the groin over there, your inguinal canal is actually parallel to the inguinal ligament. So this is your inguinal ligament over there. Your inguinal canal is parallel to the inguinal ligament, and it is supported by the structures anterior, posterior, superior, and inferior. If there are changes in the posterior musculature of the inguinal canal, then it can lead to your inguinal hernia. That's it. Okay, over to you, sir.
Yes, we said posterior wall deficiency for the inguinal problems of athletes. Yes, posterior wall deficiency. Okay, we are going on the inguinal canal. More likely, we have pain aggravated with by abdominal resistance. We have to do abdominal sit-ups. Yes, we have to do it. Please bend your knees and come sit up and come on. Sit up, please, and force me. If you have pain, no pain. We have to force it, and we have to look for the pain at the abdominal sit-up. Okay, this makes maybe inguinal related pain, but if there is a problem, it's for the inguinal related pain also. Also, the last one is pubic related pain. Sorry, I'm sorry. If our athlete, we have to look for the pubic symphysis. If there is any tenderness at the pubic area and the immediate adhesion immediately near the bone, if there is a tenderness, we can say this pain is about pubic related groin pain, because pubis from rectus abdominis muscle and also pubis adductor longus muscle, but we have athletes about pubic related. If there is an athlete with pubic related pain, there is tenderness on the pubic bone only, no at the adductor area also. And also, if our athlete has pubic problem, no specific resistance test we have to understand. Okay, and the hip problems, we talk about hip related groin pain. First of all, we have to make clinical suspicion from history, clinical examination. Our athletes say to us, I have deep anterior groin pain, perithoracentric pain, clicking, clunking, and we have no specific test for hip-related groin pain. Hip-related groin pain tests have good sensitivity, low specificity. For example, we are looking for the hip-related groin pain starting from flexion. You know, is there any problem with flexion? Or, okay, flexion, abduction, and external rotation, we are looking, okay? Faber test, also Faber test, flexion, abduction, and internal rotation. Sometimes we said it quadrant test also. Is there any pain? If there is pain, it's good sensitivity. There can be a problem, but if there is no pain, it is not about hip. We can rule out if in this position and in this test we have no pain, we can rule out hip problems also. Faber test, Fader test also. ROM is, how is the ROM? Yes, we are looking for the ROM. Yes, no problem. Yes, no problem. And we some little bit more pressure on the hip flexion. Is that a problem? And in the 90 degrees, we are looking for internal rotation. Is there a pain? No or yes. Also in external rotation, is there a pain? Yes. Okay. And we saw there is no problem with hip movement, and we can say, we can rule out the hip problem, he has no hip problems. But if he has pain, Faber test, also we can say it is about sacroiliac problems also. It's also about adductor related problems. Okay, we can go on with our presentation now. Do you want to ask any question for examination, for any examination?
Guys, if you have any questions and concerns, you can mention that in the chat box. Try to understand it's a 1 hour free live lecture. It's not like a complete hip examination. There's a lot more to cover, like the hip shin and checking for the squats and the movement impairment and the weight bear loading and the movement impairments. So there's a lot for the hip
I
part.
can say, for example, hip flexion, we are looking hip extension, bend knee fallout test. We can see all of the goniometers, inclinometers, bend knee fallout test, maybe range of motion. We are looking for the adductor problems. This is the test. Yes, we are doing this position, flexion, and we are looking from the head of the fibula and the back distance from here. Part of right part and left part also. We are looking the differences between the distance, right part and left part. This is the bent knee fallout test, okay? We are looking also, you know, hip flexors length, hamstring length also. We are looking, for example, we are looking for hamstring length. How is the hamstrings? If there is any problem with hamstrings also in our examination. Also, we are doing strength test. I am doing my strength test with, you know, microfet. Strength test is very important for groin and hip area. We can use eccentric abduction. We can use this machine for strength. Okay, we are doing our strength test. First of all, eccentric adduction test. We have to play right part, please. Take this, yeah, right, third right part, and we are looking for the eccentric adduction for the left leg. Please push my hand down. Yes, I am looking for the eccentric adduction. Okay, this is the strength for eccentric adduction, and I have to look the other part also. Lay down the other part, and we are looking the other part also, but I don't do now. The second one, eccentric hip abduction. Okay, eccentric hip abduction. How can we do it? Lay down, please. The other, I'm looking with the other leg. Yes, this is the position. We are doing in this position. Please push my hand. Push my hand, push. This is the eccentric abduction test for hip. And the third one, adductor squeeze test at 45 degrees. Please lay down and bend knee for 45 degrees. And I am looking for adductor squeeze test. Squeeze my hand, please. Squeeze. This is the most important test for hip and groin area also. Okay, we are looking for the strength of adductor squeeze at 45 degrees. Also, we have to know adduction and abduction strength ratio. In our athletes, in some articles, adduction strength is 20% more from abduction ratio, abduction strength. Okay, adduction is more. Adduction is 10, abduction is 20% low, 8. Have to be. But in our area, if we are working with an athlete, we have to know pre-injury levels. Pre-injury levels are important. We don't know dominant part, and because we have some differences between dominant and the other part, we have to know the pre-injury values of the athlete. It will be better for us if our athlete have a problem of groin injuries. Maybe past year he or she has problem with groin injury. We have to look in this year also the strength. We have to make the strength better also. Hip internal and external rotation strength we are looking also. You know, hip internal and external rotation strength. Yes, please push my hand to the inside. This is for hip external, internal push outside, yes. But we have to make it for holding. We have to make, we have to hold the athlete. Some athletes have lots of power, and we have to, and the last one, I want to say hip adduction strength at outer range. It is most important for our athlete also. I showed you also, and outer range. You have to look at the outer range. If there's a problem in this area, you have to take the outer range. In the rehabilitation part, and please push my hand. Push. Yes, we take this power and we write it, and we are looking for the future. Okay, hip adduction strength and at outer range also. Okay, these are not enough for me, but I want to talk you with presentation, because we have to look for endurance for the athlete. How can we look for the endurance? Plank, side plank, abdominal sit-ups, oblique sit-ups. We have to look Copenhagen adduction test, sit to stand test, calf raises, and also lots of tests, functional tests we have. You know, maybe I will show you. We are looking for the plank for the athlete and record the time of the plank. We want from our athlete for make planks for 3 times. And how is the function? Plank times, how is it? Side plank times, abdominal sit-ups. How is the abdominal sit-ups, oblique sit-ups? We are doing Copenhagen adduction test. It is the most important test for the groin area, for the injury prevention. We will talk about it. Sit to stand test. We are looking for the knees and for the quads. You know, sit to stand test. Calf raises also very important for the groin and hip area. We will talk about this. And also, what I want to say, the last one is the functional test. We are looking for the athlete's single leg squats. Please come on. Make me one single leg squat. Yes, we want our athlete to do single leg squat. It is the most important one, functional test. We are looking for any abnormality for the hip area. Is it going down properly, or is it going down inside? If there is going inside, there's a problem with hip abduction power. Okay, we have to correct the powers. Also, we are doing star excursion balance test, triple hops, sideway hops, change direction tests. We are doing lots of tests also for our athletes. In hip and groin area, also we don't forget about lumbar spine and the ankle dorsiflexion and the knee quadriceps function. These 3 areas are very important, because lumbar spine is important, because referral pain maybe there will be. We are looking for the lumbar flexion, lumbar extension, lumbar side bendings, and lumbar the other examinations. Also, we are looking for ankle dorsiflexion. How can we look? We want our athlete to make some dorsiflexion and going to the wall. I will show you in the presentation also. And I said to you also, knee and quadriceps function is important. Single leg squat test we are doing also. Can you make single leg squat test for me one more time? But this is front. Okay. Yes. For example, he has low quality for the test. Low quality, because his knee is going medially. It's not good for our athletes. His knee, can you see it? Maybe you can see it. I will show you in this position. Can you do it? Knee is going medially. It's not good for us. It has to be same plane. Okay, it says to us the power is low for the abduction. Okay, yes. We can go on from the presentation also. Dr. Parijat, can we take presentation also now?
Yes, sir. You can start sharing. Yes, sir. Dr. Ufuk, will it be okay if I share an article by Dr. Cameron McDonald?
Yes, now is good. We can go.
Okay. So let me try to share, if I can share, Dr. Cameron McDonald's and Dr. Steve Short. Steven Short is one of the sports physio for Denver Nuggets. It's a basketball team in the USA, Colorado. And Dr. Steven and Dr. Cameron McDonald, they work together. So this article, if you see on your picture, it says like the hip and the groin injury prevention in elite athletes in the team sports, especially the basketball people. Now they have talked about the court and the field athletes, whether it's amateur athletes or whether it's a seasoned athlete, and hip and groin injury, which is the Hagi. So if you see the algorithm over there, groin pain, Hagi is the hip and the groin injury. The pathoanatomical and the differential diagnosis, as Dr. Ufuk was mentioning, it could be an adductor problem, inguinal problem, hip-related problem, pubic-related problem, rectus. Now, your groin pain, don't miss the regional interdependence. Like ISOMT, at ISOMT, we really focus a lot on the regional interdependence. Our cohort manual therapy program, 1-year program where you become a certified evidence-based orthopedic manual therapist. 1-year manual therapy program, the applications are currently open. And we really teach you the regional interdependence, because your groin pain in an athlete or in a layman can actually be also coming from your lumbar spine, can also be coming from your thoracolumbar junction. Okay, thoracolumbar junction, it can be because of your genitofemoral nerve or your ilioinguinal nerve. Ilioinguinal nerve is supplying the sensory part of your groin, and the genital branch of the genitofemoral nerve is supplying your some muscles, say for example, cremasteric muscles in males, spermatic cord, and there's a ligament in the female that it supplies. It can be coming from the lumbar spine or the sacroiliac spine as well, especially the groin pain. Okay, thoracolumbar junction, it can be called like Magnus syndrome as well. So those athletes can have a problem in their pelvis, the sacroiliac joint, the lumbar spine, and the thoracolumbar junction, where the pain can be because of the groin pain, can be because of that. Okay. Now, if you see carefully, I'll just come to the end of this. I know Dr. Ufuk has a lot to cover. I'll share this article with you all. It's a very nice article by Dr. Cameron McDonald. There are like movement assessment, there are strength assessment, and as Dr. Ufuk was mentioning about the ratios. So now when it comes to the athlete, the adductor and abductor strength ratio, the flexor and the extensor strength ratio at the hip, and the trunk flexor and the trunk extensor ratio as well is compared of these athletes to kind of target the movement properly in their sporting event. Okay, you can do some special testing. There are certain sports functional testing that Dr. Ufuk was talking about, and the intervention is carried accordingly. Okay, so I will not hesitate to share this article. But if there is an intra-articular or bony problem, Dr. Ufuk, as a sports medicine physician, he knows that the athlete might undergo a hip arthroscopy. Now, the hip arthroscopy through ultrasound, whether it's a labral issue or a muscular issue, the surgeon can work on the hip, and then again, it's a part of the physio to do a proper rehabilitation. Okay, so there are certain levels which are the construct recommendation for the groin injury rehabilitation. Like you have to do a proper segmental motor control and strengthening. Then you can start with some linear drills and running, and some multi-directional drills and sprinting. I guess we will show you some exercises today. But yeah, we are generally talking about the sports or the physician or the physio's sideline assessment or the dressing room assessment. These assessments are not done on the field, because we had a question from the participant, Dr. Ufuk, that are these assessments done on the field? No, you don't have so much of time to do these tests on the field. Okay, it is your discretion as a sports physio or as a sports doctor whether to take the athlete off the field, because on the field you just get like 10 to 30 seconds. There are sideline assessment and there are dressing room assessments as well. So it's totally up to a sports physio what to decide at that particular instant. Over to you, sir. Thank you. You can share the presentation now.
You see me also?
I see you also, sir. I see you. I see your presentation also.
I talk about adductor related. First of all, I talk about adductor related groin pain. Also, I say local tenderness, pain on resisted adduction test, This is the resisted adduction testing. Resisted adductors testing is outer range for athletes. I talked about this and showed you also. And iliopsoas related pain, we are looking for local tenderness, pain on resisted hip flexion, pain on hip flexor stretching, also Thomas test, and pain on resisted hip flexion. Also inguinal related pain, pain in the inguinal canal region, tenderness, no palpable inguinal hernia. If you take palpable inguinal hernia, it is about other. I will show you also. More likely if pain aggravated by abdominal resistance. This is the abdominal sit-up test. Sometimes we are doing Valsalva, cough, and sneeze also. Pubic-related groin pain, we are looking for tenderness, I said to you. Hip-related groin pain, the little part of our patients, clinical suspicion is important. History, clinical examination, deep anterior groin pain, peritrochanteric pain, clicking, clunking, no specific test, but these tests for rule out. If you have no pain in Faber and Fader and Romi's range of motion is normal, you can say it is about less likely to be from hip, okay? But we don't say, yes, Faber is positive, it is about hip. No, Faber may be positive about sacroiliac, maybe about the other issues. Adductor-related groin pain makes Faber positive also, okay? Our examination is important. And also, I told you about apophysitis for young patients, anterior sphenoiliac spine, sartorius for sartorius, anterior inferior iliac spine for rectus femoris, pubic bone, apophysitis for young athletes. We know pubic bone pubic bone is also apophysized for 20 or 21-year of athlete also. Also, not be missed, I said to you, stress fracture. I said to you, inguinal hernia. Inguinal hernia is the other part, I said to you also. We don't forget about stress fracture. Single leg hop test, we can look. Neck of femur. If we have any suspicion about this, we have to make X-ray and MRI investigations also. We will talk about this. In female athletes, we have to be careful for gynecological conditions. We talk about hip joint also, avascular necrosis for steroid usage, arthritis for the hip joints. We have to be careful for Perthes disease also in children. But how can we be careful if he or she has night pain? We have to be careful. I have night pain. We have to be careful. We have to look more investigation, okay? And the other weight loss maybe weight loss also, and the red flags also, okay? Testicular tumors for young male athletes, we have to be careful also. Okay, I don't say one more time same things. I'm using range of motion tests. I said to you internal external rotation at 90 degrees and hip flexion, hip extension. This is bent knee fallout test. We spoke about this also. Muscle length, Thomas test for iliopsoas length. We spoke about this also. Bent knee fallout for abductor tightness. This is bent knee fallout test. We measure this how distance, this part and this part, both of parts, right and left also. Hamstrings, we are looking for hamstrings also. Also, I talked about strength, eccentric, adduction, abduction, abduction. Squeeze test is the most important part in this area also. We have to look for squeeze test, and squeeze test must be better day to day. And rehabilitation, we are using these tests also. Adduction abduction ratio, we spoke about this. Asymptomatic football players ratio is 1.2. A deduction is 20% more. Okay, hip internal, external rotation strength, hip flexion, extension strength. We talk about all of these also. And strength, the other position. This is for iliopsoas strength. We can do it. We can do it with belt. It's better for us to do with belt. And I talk about outer range strength for our athletes also. This strength is more important for us also, because in the rehabilitation part, we are looking for this strength. Outer range strength is more important, okay? And if we are working with an athlete, endurance is most important place. Functional test most, endurance is also very important for us. Plank times, side plank times, abdominal sit-ups, and Copenhagen adduction test. We will spoke about this test. Sit and the sit to stand test for quads and knee. For calf raises is important for endurance also. We can make all of these for testing the athletes. And also we spoke about a functional test, single leg squat test, stairs excursion balance test, single leg hop test, sideways hop test, Illinois agility test, and the T test for the athletes we are looking for, okay? We start from here, going here to here, and I can't show you. Oh, we start here, going to here, and then finish the test. And we are looking for the time of the athlete, okay? And going on, neurodynamic test is important in this area also, because we have two nerves, femoral nerves and obturator nerve. From L2, L4, we obturator nerve also for adductor muscles. Femoral nerve, slump prone knee bend. As same as we are doing for slump and knee bend, and we look about pain, tingling, and any problem for the athlete, okay? Obturator nerve, we are doing at this position also. We are doing some abduction, knee flexion, the other leg, and we are doing abduction. Also, we are looking for tingling, any problem, okay? Another joint we talk about, lumbar spine, ankle dorsiflexion is very important in our athletes also. We are looking in the rehabilitation, we are making the ankle dorsiflexion is better also. Okay, investigations. We are doing investigations, but the diagnosis clinic, I said to you, no investigation. We don't need it, but investigation may be helpful. Which muscles are involved? If we have adductor related problem, we have to know grade. How is the grade? How is the problem? How large the lesion is? Radiological examinations are often very helpful also for red flags, also elite athletes, also young athletes, soccer players also. Ultrasound and MRI may be used, can be used, also visualize the injury also. MRI and I want to take this, okay, this here, okay. MRI and X-ray also indicated in children, adolescents with avulsion, suspicion of avulsion, physiolysis, okay. Growth plate disturbance of the proximal femur. If we problems about neoplasms, we are looking for neoplasms, we are looking for MRI also. X-ray, we are using pelvic X-rays on a standard pelvic X-rays. If we have young athletes and problem with apophysitis, we will speak about this. Here is the anterior inferior iliac spine. This is the apophysitis of the anterior inferior iliac spine, okay? Rectus femoris insertion. And the other part, the came morphology, femoroacetabular impingement, both hip has femoroacetabular impingement also. We are doing AP and lateral, but lateral AP pelvis with internal rotation 15 degrees. We need internal rotation for the patient to look hip joint better. And also we are doing another X-rays, AP pelvis X-rays and down lateral view. We are doing down view. AP X-rays, we are doing 15 degrees of hip internal rotation, okay, or standing. Down view, we are doing 45 and 90 degrees of hip flexion, because improve evaluation of femoral head neck geometry better. If you are looking for cam morphology, we have to do down view. If you look for acetabulum, we have to do AP X-ray with 15 degrees of hip internal rotation, okay? I want to show you some places and anatomical structures. These are anatomical structures. This is normal. Upper part is normal AP X-ray. The under part is UC chem morphology, loss of normal femoral head neck junction. The angle of we are using alpha angle for this pathology. Alpha angle is the measurement. We are doing it in MRI and X-rays. Alpha angle up, if it's up to 60 degrees, we are looking for chem morphology. We can say chem morphology. And in this lateral view, down view, there is no problem. This is normal view. And the down part below, at the below, we see pincer morphology. Pincer morphology, lateral ossification of acetabulum. This is central edge angle. Central edge angle we are looking for. The chem morphology up to 60 degrees is normal. Central edge angle is 40 degrees. In this position, mixed type of impingement we see. Chem morphology and pincer morphology, okay? Ultrasound and MRI. Ultrasound, best resolution for tendon imaging. If you are problem in adductor tendon, iliopsoas tendon, you can use ultrasound very, very good, because ultrasound is very good for tendon imaging. And you are doing dynamic assessment. Dynamic assessment is very, very good thing for you. And you can correlate your structures with location of the pain. When you use your ultrasound, put ultrasound down up the pain area and you see where is the pain. The pain is about iliopsoas. The pain is about adductor. The pain is about pubic. The pain is about also inguinal, okay? MRI, we can use MRI for bone ödem, femur stress fractures. I said to you, single leg hop test, you can, and acute injury, maybe trauma is important also. MRI for aponeurotic tears. Sometimes we have tears, we can show it in ultrasound very well. If you have aponeurotic tears, you have to make an MRI also. Hip joint pathology, if you have suspicion about hip joint pathology, you have to do MRI. And I want to show you some adductor muscle problem. Here is the pubic bone, here is the adductor longus muscle, and the tendon thickening you see in this position. Here is here is the hypocaque area, you see it, and this part of the adductor longus has pathology. And you see the other part here, but this part tendon has thickening. So one of the problem is tendinosis, thickening of the tendon, and the problem is in the hypocaque problem, maybe tear, okay? We have tear in the adductor longus. Below the adductor longus, we have adductor brevis also in this area. Also, we can show it. This is for longitudinal imaging. This is for transverse imaging for the adductor longus tendon. Problem with the tendon also, tear. The problem is the tear of the tendon, okay? And I want to show you big muscle tear. If you have a big muscle tear, you have to make MRI also. You have to show it. You have to see it also. This is adductor longus tear also in both position, okay? AP and transverse MRI imagings. And I want to show you the symphysial chains, which may not be always clinically relevant. If you see these chains in the athlete, it can be normal. Asymptomatic players has these changes also. You know this SMS lumbar spine. Everyone has lumbar disc. Every athlete has or have symphysial chains. And symphysial chains don't tell us anything, okay? If he or she has pain on the pubic area, yes, we have to know what is the problem. But he can be asymptomatic on the pubic area also, okay? This is normal. This is about playing soccer. If you are playing soccer, you have symphysial change also. Okay. Thank you. And also, I want to show you the MRI findings in soccer players, adductor-related groin pain, and asymptomatic controls. I told about this. A high proportion of asymptomatic soccer players displayed positive MRI findings. The positive finding is this: bone marrow edema also. Okay, positive, and also a little bit problems at the adductor attachment point also. If you see these, yes, pain is problem from here. No, clinic is important. Examination is important. If there is no tenderness on the pubic bone, no problem from pubic bone. If there is no problem with adductor squeezing and adductor palpation, no problem about here. Okay, we don't diagnose from MRI. We diagnose from clinic. Also, we can use MRI arthrography for the cam morphology, for the intra-articular, periarticular problems. Okay, if we have problem in the labrum, we can use also MRI arthrography, because you see acetabulum, hyalum fibro. Here is the articular cartilage B. C is the labrum. You see it. The best way to see the labrum, you have to use MRI arthrography. Same as shoulder. If there's problem with slap tears, we have to make MRI arthrography also for our athletes. Okay. And CT scan we use little, very little. Only sometimes our surgeons use CT scan for surgical planning also. Three-dimensional reconstruction, femoral version analysis, for femoral version analysis, and useful for surgical planning. Okay, I want to talk about treatment. Treatment part is very good also. And per Holming, I want to talk about per Holming article, effectiveness of active physical training, long-standing adductor-related groin pain. We said about long-standing 2 months, up to 2 months. Manual or exercise therapy for long-standing pain, Weir and friends, randomized controlled clinical trial, and Nicola Bisciotti made a critical systematic review also. Good to excellent result, exercise-based rehabilitation. Exercise-based rehabilitation can be effective. Okay, these are the level of evidence and grade of recommendation. If we have an athlete about adductor pain, adductor-related groin pain, I always advise him compression clothing therapy. Okay, first. Second, manual therapy, strengthening and exercise. I tried it. If he is not good, I will do prolotherapy. The third way for me. How much I wait for nearly, but it's important about level of play, athlete play, and when I am doing prolotherapy. I am starting with clothing therapy and manual therapy and exercise. If athlete has more competitive athlete and has lots of problems and has lots of matches, I want to do prolotherapy after 2 or 3 weeks. Okay, I have to try it. Also, corticosteroid injection therapy conflicting nowadays. PRP treatments has no articles, good articles for PRP treatment, and intratissue percutaneous electrolysis. I am using this also my groin pain athletes. Okay, we will talk about this. Also pulse dose frequency, also radio frequency. In this article, Weir and the friends made this article for the manual therapy. First article in 2009. Their ways the treating physician controls the tension. I want to take how can I take my mouse? I want to show you something, but okay. In the figure 1, you see the manual therapy technique. You see the technique. Circular motion is used to apply maximum tolerable stretch to the adductor muscle group. After performing the movement, athlete stays laying on the table and the adductor muscle compartment is compressed using one hand, while the other hand moves the hip into adduction and slight flexion. You see it, figure 2. Okay, this circular movement followed by compression lasts approximately 25 seconds and is repeated 3 times in one treatment session. And after the treatment, 5 minutes warming up each day, slow jogging, cycling also, stretching also. And the previous treatment of these athletes, you see that in the table 1, physiotherapy modality is made, previous treatment, also structured exercise program, osteopathy also. And after this manual therapy treatment, level of satisfaction, you see 71% treatment, good and excellent. You see it, level of satisfaction. Oops. I want to take my mouse, but I don't. Where's my mouse? I'm sorry. Okay. The importance of this article is, you see here, manual therapy is important. 71% excellent and good satisfaction after treatment. Okay. Okay, treatment strategy. We have to educate our athletes. They have lots of pressure about teammates, about coaches, about families also. We have to educate. We have to educate them how they will be better day to day. Maybe we will talk about day to day also, okay? And we have to make range of motion better, strength, endurance, functional training, balance training. Core strength is very important. We have to make progressive core strength training, core stability, sport-specific weight training also. The Helmy protocol, the Helmy and their friends, they made the protocol at 1999. The protocol, first 2 weeks, the Helmy says, static adduction against ball, knee extend. Static adduction against ball, knees bent. 30 seconds, 10 repetition. Abdominal sit-ups, straight and oblique. We can show you also with my friend if you want, but maybe you can see it from our here also. Leg abduction, the second module, in first week in this Helmy protocol, we start these 6 exercises. And the second module after 2 weeks, from third week, we start perform twice each session. Leg abduction, adduction, sideline, low back extension, prone over a couch, standing one leg, weight pulling, abduction. Maybe I show you all of these. First 2 weeks, we start with 1, you see it, static adduction with knees, static adduction against ball, I show, with knees bent and knees forward. Sit-ups, and 5 and 6, you see, I want to take my, I have a problem with my, okay. I'm sorry, I have a problem with my mouse. You see it, after 2 weeks, adductor, abductor. In 2 weeks, we are focusing for adductor and abdominals. After 2 weeks, we are starting for abductor, low back, and coordination also. You see the other exercises, cross-counter skiing, 14th part of the exercise, okay? I want to take my mouse, but I can't see it. I can't take it. How can I take it? Okay, there is a problem. And coordination is very important for us. Okay, very good. Coordination, you see 15th exercise in the second module. We are using these exercises until symptom-free, okay? We have to make symptom-free for starting return to sport. Okay, I talk about the examination. I said you program Copenhagen adduction exercises. We make very good reduction in risk groin problems, 40% reduction for pain, and injuries. Okay, we have to do it with our group. We have to do it not individual. We have to do it with all of athletes, with our team. This is the adductor at the Copenhagen adduction strength program. In first week, weekly session 2, sets per side 1, repetition per side 5 times, 3 or 5 times. Second, you see it. I want to use my mouse, but I can't use it. Why? Where's my mouse? Okay, go on. You see it, the Copenhagen adduction exercise is very important for our athletes because high adductor muscle activity we have. Eccentric adduction strength, side bridge endurance is going up. We are doing in season with this 8-week progressive training program, large significant increase eccentric hip adduction, abduction strength. Okay, we are starting 1A from 1A. You see it at the first 1A, 1B, and going 2A, 2B, 3A, 3B. What are the differences? Maybe I will show you with my brother. Can I show you Copenhagen adductor exercises and these exercises with my brother to you? If you want, I can show you. Dr. Parijat, you hear me?
Dr. Ufuk, you can show. Not a problem. Take your time. You can show.
But it takes some little time. Is it good or not?
No problem. You can take your time, sir. You're going great. Take your time.
Okay. Okay, we can start with, I'm going with my brother. Hello. Shafak, come on, please. Come on, please.
Dr. Ufuk, do you mind stopping the presentation share, please, so that people can see you big and clear also?
I can't use my mouse. What is the problem? I don't understand. Is it good now?
No, we can still see your presentation. Just try. Oh, you know what? I can try it for you if you want.
I can't use mouse.
Wait. There we go.
There's a problem with my mouse.
You can do the demonstration. I've stopped sharing it.
Okay, thank you very much. Yes, but I want to see you also. Yes, because I want to use my camera. First of all, we are starting with the exercise of, we said, static adduction against ball. Please lay down. Can you see me?
We see you,
yes.
Sir. We see you. We see you. Yep.
I want to show you my athlete. Take the ball, please. Knees bent and squeeze the ball for 30 seconds. Okay, static squeezing. Adduction, static adduction against ball. Knees extended, knees bent. But we start with knees extended. Okay, knees extended. You see it, maybe. In this position. Yes, please squeeze the ball. This is the first. The second is knees bent. We want knees bent and squeeze the ball, please. Yes, this is the second part. The third, we want, abdominal sit-ups, straight and oblique direction. I want to show you my athlete. Yes, come on, abdominal sit-ups, right. And oblique direction, please. Yes, yes. This is the third one, abdominal sit-ups, oblique, and 5 sets 10 repetitions. Combine abdominal sit-ups and hip flexion with ball between knees. We are doing also. Okay. Yes. Stops, please. Between knees. Okay. Third one. Oblique, please. Yes. Squeeze and sit-ups. Okay. This is very good. In first 2 weeks, this one is good. And the balance training for 5 minutes. We are doing balance training. Please get up. stand up. Take this one for the balance. Yes, we are doing balance, single leg stance. Yes, and okay, focus position. Yes, we are doing single leg balance and balance training for 5 minutes. And the last one, sliding board with feet parallel apart, 90 degrees angle. I am using my, where's my, okay, I'm using, take this, sorry. Yes, take this up, take this up. And the last exercise, we are doing sliding board with parallel and apart 90 degrees. I will show it you. You show it. Please take this one also. Yes, take this one, this one. Yes, take this. Yes, sliding board, parallel and apart. Okay, this is very good exercise. And the last exercise for performing 1 minute, 5 sets for each leg. Okay, this is first 2 weeks exercises, Hermic protocol. And the other part, the second part I told about, we are doing abductor. Please lay down. Leg abduction and adduction with sideline. Please sideline. Yes, take this leg here. You see me. Leg abduction and adduction. Yes, you see it. Adduction. Yes, this is the adduction. For after 2 weeks, we start for adduction, and the other part, turn the other part, and abduction also. No, this is adduction also. We are making abduction. Yes, abduction. Yes, this is abduction. Also, we are doing, you see, yes, abduction. Yes, abduction. Okay. Also, we are doing low leg extension prone over a couch, 5 sets. Standing one leg, weight pulling, abduction and adduction. I will show it for you at inside. Maybe we are doing also, come on here. We are doing also with TheraBand exercises. TheraBand exercise. We start to do TheraBand exercises. Take this TheraBand. You see your thing. Yes. But turn. Yes. Abduction and adduction. In this position. Turn me. Yes. Go on. Yes. Yes. This is adduction for turnaround. We are doing for adduction also. Okay. TheraBand exercises also. We are doing cross-country skiing. We are doing, I want to show you cross-country skiing also. Also, we are doing balance training at this time. Skating movements also. We are using up to 2 weeks weight machines, hip abduction machines. Also, we are using machines. I will show you maybe in the presentation also. Maybe cross-country skiing, I will show you also. We are doing some bed exercises also. I can show you. Come on, someone please. 12. Yes, come on. Lay down, please. Lay down on the bed. Lay down. This position. I will show you. In this position, come back, come down. Back, down. Yes. Down, down. Here. Come on. Yes. Make your leg up and down, please. Yes. Pick up. One more time. Yes. Now. Can you see? Yes. This is the exercise also. I will show you exercise in the presentation, the other exercises also. Going on the presentation, please. Yes, we are going on the presentation also, please.
That was a great demonstration of the techniques of the exercises, Dr. Ufuk.
I want to show you cross current counter exercises, but
yeah, we are kind of
my friend is not.
Yeah, over the time a little bit. So
my friend is not. He is not athlete also. Yes, maybe I will show you in this area. Can you see my picture?
Yes, sir. We can see it.
Yes.
We can see it.
This is cross country skiing exercise. I want to show you. This is adduction exercise, abduction exercise. After 2 weeks, I show you sit-ups with ball, and we start for low back coordination, and we did it. Teraband exercises, slide boarding exercises, balance training, important also. Also, we are doing some skate, some lateral goings we are doing also, okay? Yes. I want to show you Copenhagen adductor strengthening. In this, we start with A deduction and A deduction at here, 1A, 1B, you see A deduction. In the second part, we only make hold with 2 hands and make athletes up and down also. In the third, grade 3 is the more challenging, and the grade 3A, we are making support from both of our hands, from knee and from ankle, and the grade 3B, we are doing only from ankle supporting, little bit light knee support, no knee support, light knee support, okay? Athlete is doing better in this area. We are supporting him with left hand, with ankle, the most challenging part, okay? So in the pain management, I talked about compression shorts activation because compression shorts make the reduced activation of adductor longus muscle and reduce the load of adductor longus antesis, okay? Contributing to the improvement of pelvic stability. Because we need stability, because we are doing core strengthening also, we are doing, and also we are reducing muscle oscillation with compression shorts. Another theory in this part, it can be maybe placebo effect also. Some of articles says it can be from placebo effect. I don't know, because I believe in muscle theories also. Also, manual therapy and exercise, we are using, I said to you, isometric adductor exercises, Holming and Friends, abdominal strengthening, balance training, skate movements, transversal friction massage, manual therapy, stretching adductor muscles, complemented, also laser therapy, transcutaneous, electrostimulation, and in this literature, they made program based on activation training is more effective than program based manual therapy and physiotherapy. Active training is important. This is active training, okay? We have to make active training because we are dealing with athletes. Athletes has to need active training, okay? Also, at the Weir and Friends study, they made G1 and G2 groups. In the G1 group, they made performed home-based exercise rehabilitation and structured plan focused return and training. And G2 rehabilitation, they made heat therapy, manual therapy, stretching, specific return to playing program. And they said in both cases, in G1 and G2 group, all G2 group allowed for a quicker return to sport than the exercise therapy group, okay? Because in this literature, in this study, we see G2 group only quicker return. And I can say 2 treatments were very effective. same effects. But G2 is little bit faster to G1. They made in G2 heat therapy, manual therapy, stretching, and specific program. Okay. We spoke about this exercise therapy in this, and they made same manual therapy. Weir and friends start to make manual therapy in this area. They made manual therapy, and in the literature they have so many studies, and they made same manual therapy technique. I told you about this technique. Same technique, and the effective is the same. Okay. So Igor and friends earlier say that in their literature study, early return to sport seems possible and safe after manual therapy of the adductor muscles in soccer players in the short term. What are they doing? Manual stretch for the adductors, 3 repetition, 10 seconds. Adductor stretch in favored position also, you see it, for 15 seconds during 1 minute rest. Demonstrate adductor stretching as home exercise also in C part. This is your home exercise, they say to athletes. After consultation during 2 weeks, daily adductor stretching, 3 repetition, 30 seconds. And self-guided symptom-based return to sport. Also, they see early return to sport about manual therapy techniques, okay? Also, Yusufzadeh and friends made study with patients, 15 male athletes suffering from long-standing adductor pain, and they see no adverse effects. Also, Helmi protocol, they said, is safe and very good, but they are doing, the authors underline that necessary to give more emphasis to the adductor muscle eccentric strength. They say we have to be careful, adductor muscle eccentric strength, effective than the classic Helmi protocol. Okay, we have to make adductor muscle eccentric strength more, they said in their study. Also, we are doing injections. I said to you, corticosteroid injections I don't do nowadays, because if you are doing in the tendon will be weaker than the before. Corticosteroid we don't use a lot. Some area, little bit area. Prolotherapy I'm using more, because prolotherapy makes regeneration in the tendon. Most of the problem we see in adductor and groin is the tendon problem. I said to you, hip and groin pains, about 70% is about adductor related groin pain, and prolotherapy very helpful for them to return to play, for make the tendon more stiff also. Intra-tissue percutaneous electrolysis therapy I use also. I'm using it with dry needle, same as dry needle, acupuncture needle. I made acupuncture needle into the tendon and give electrotherapy for the needle, and I look for the effects for the patient athlete. Don't make their pain very a lot. I ask to my athlete, how is the pain? I give electrolysis, electricity, and I ask to them, how is it? SMS TENS, transcutaneous electrical stimulation. I give electrical stimulation, and I'm asking also, and we are doing electrolysis. Same as prolotherapy, it affects also intra-tissue percutaneous electrolysis. Platelet-rich plasma therapy, we have not lots of studies in this area also, but we can use also some of strains, some of problems for adductor problems. Also, I am doing intra-tissue percutaneous electrolysis and also platelet-rich plasma therapy in same session sometimes. Pulse dose radiofrequency is good also, but we have to do more studies at these areas. In the rehabilitation time, we have to be careful tissue loading. We have to ask our patient, don't make any exercise that you make your pain up to 30%. 30% is maximum level for us. If any exercise makes your pain up to 30, we don't need this, because I think the regeneration of tendon is going worse about going pain up to 40%. Okay, I'm saying my patients, all of patients, don't make your pain up to 30. You feel 30, 20, it's good. You feel pain also, but not up to 30, okay? And we have to know the adductor exercise, which exercise is the best for adductors. We are looking for, this is the study for Andreas Cerner and friends made this sentence, this study, and the study is very good, and they are doing isometric, these are high exercises, these are low exercises, you know, isometric adduction, adduction with ankles, you see. Copenhagen adduction, I talk about this. I'm sorry. And, oops. Adductor machines also, sidelining adduction, spine bilateral adduction, slide board, and adduction with TheraBand. They use these exercises. The best exercises are these three ones: Copenhagen adduction, hip adduction with TheraBand, and side lying adduction. Okay, you see it. These are Copenhagen adduction and hip adduction with TheraBand and side lying with adduction. These three ones. You see the differences. EMG differences. Okay. With these exercises, changing is more. And also, you see the exercises at here. EMG study. Specific hip adduction exercise displays different levels of adductor longus muscle activity, indicating differences in exercises intensity between specific exercises. I said to you, we can say Copenhagen adduction exercises, hip adduction exercises with an elastic band, and dynamic high intensity exercises. These are the dynamic high intensity exercises. Okay, therefore they have great potential. These exercises have great potential for on-field prevention and treatment programs. We said 3 exercises. Okay, these 3 exercises, the best exercises. And also, if we have iliopsoas problem, we have to make iliopsoas isometrics. We have to make iliopsoas strengthening exercises this way with TheraBand also, and this way also. Okay. Also, if we have inguinal related problems, we can use machines also, obliques. We have to make oblique strengthening, also sit-ups with straight and oblique stops. Also, we can make marching, okay, with laying down. Legs are together and straight, and pass one foot under the other. What we need for the athlete: trunk muscle function strength, trunk pelvic core stability, quadriceps strength, hamstring function, calf function, balance, and proprioception. Okay, we have to make all of these best, because we need from athletes the best performance. Also, in return to sport, we make education for the pressure from coach, teammates, family, the time of healings. If you have, for example, if you have grade 1, grade 2 adductor strain, it takes 2 weeks to heal. If we have grade 3 adductor strain, it takes nearly 78 days, maybe 80 days. Okay, we have to talk about them, given the realistic time frame. Also, we have to look for individual. We are using protocols, but we have to look our athletes. We have to be individual, because some athletes need some motions. Some athlete doesn't need some motions. We don't make, but these are the using pain provocation tests for return to play. Prevention is very important. Sport-specific injury risk, we have to know this. Soccer plays, I said to you, ankle is the most, hamstring second. We have to make, in this time, we are doing sometimes no playing, no training. We have to make ankle better. We have to make hamstring better. This is the Nordic hamstring exercise. We have to do Nordic hamstrings in the rehabilitation time for groin injuries, because athlete needs hamstrings a lot in soccer, because it's cutting. There is a lot of cutting movements, and we have to make it very good. Cardiovascular problems in the rehabilitation time, we have to do bike cardiovascular training, swimming in the swimming pool also. Also, we have to do balance training. Sport-specific skills are very important. Nowadays, we are the future of the athletes is going video analysis. Video analysis is very important. Kicking, sprinting, change of direction. There are lots of articles about these kicking, sprinting protocols, but I don't put in this lecture also. Load management we have do. Also, I can little bit say about surgical intervention. If we are doing all of the treatments, but there's problem with athletes, sometimes problem with posterior wall weakness, we can say. There is a Moshevic repair technique. It's minimal repair technique for the athletes, and it is good for our athletes. You can post-op rehabilitation is this: lift up the ventricular immediately, resume running, cycling post-op 2 days, begin specific training on 3 or 4 days, full training day 5. In professional athlete, 70% nearly return to play in 14 days. Also, we are using, I said to you, video analysis, systematic video analysis for the players. Example of categories: how was the injury happen? We are looking change of direction, kicking, reaching, jumping, and the injuries occurred in first of all, I can say in non-contact situation. We see the injuries in the athlete in non-contact situations, 70%. And also change reaction to a change in play, it affects. Injury actions, change of directions, kicking, we can say change of directions, reaching injuries, 60%, closing change movements. We have to know the athlete and athlete trainings and athlete sport-specific movements. It will be very good for us for rehabilitation also. Also, future, we said about rapid muscle activation. Muscle is undergoing rapid lengthening, may be considered fundamental injury mechanism for adductor longus injuries. Training is important, increasing the capacity, lengthening states, training and testing, and all of these tell us about if we have problem with athletes, past injury, or we have to know the strength also before injury. It is important for us also. Also, player action, you have to know the action. Maybe you have to correct the movements with your athletes. You have to talk to them, individualized, and you have to play with them very good also. You have to be near to them also while they are making exercise, because they have to do exercise good, in good motion, in good way. Okay. Also, I want to take the last presentation. Primary prevention, FIFA 11 plus is very good advice for us, for our athletes. Group exercise programs, and determine the risk factors and athletes pre-injury values, I said. Secondary prevention, early detection, appropriate intervention, and tertiary, we reduce complications, effective injury rehabilitation, and prevention is very important. Maintain fitness and risk factors, the other injuries. Thank you very much for your patience. It's
No, Dr. Ufuk, that was a quite elaborate lecture. It wasn't actually a lecture, it was like a proper course. So thank you so very much for that elaborate, detailed presentation on hip and groin injuries in the athletes. Guys, we understand there's a lot to cover. We really thank Dr. Ufuk to do on a weekend morning. I guess it's afternoon or evening over there in Turkey, directly live from Turkey. We really thank you guys, and we apologize to go over a little bit over the board of the time, but believe me, there's a lot to cover. If you want to learn more from our experts, you're welcome to join our cohort program, manual therapy, 1-year manual therapy program. Our applications are currently open. We will share you the information on the WhatsApp groups and all. You're welcome to follow us on our social media. And the lecture recording of this and the certificate, people know we generally give it to our ISOMT premium members. So you're welcome to check our website, theisomt.com. People who are new, I can mention that in the chat box. It's called the isomt.com. We really thank your patience, everybody, to come on a weekend evening and learning from our international experts like Dr. Ufuk. Dr. Ufuk, once again, thank you so very much for this elaborate presentation. And we hope to see you more in our future courses and lectures. All right. I'm Dr. Parijat Kumar. Yes, sir. You want to have a last word?
We will be in the courts. I'm waiting for the courts. I am in the court also. I am listening your lectures also. I'm very happy to listen to you. And I thank you very much for your lectures. And they are informative, very good informations you can take in the lectures also. Thank you very much. We are waiting for the courts for participants, and thank you very much. Thank you for your patience.
Thank you, sir. If you want to upgrade and upgrade your manual skills and your work professional ethics, etiquettes, and your financial things, guys, please remember you are welcome to join our 1-year manual therapy program. It's because we believe that you can't become a manual therapist in like 5 days or 10 days. It's a motor learning process. So you're welcome to join our cohort manual therapy program. Our applications are currently open. You're welcome to kind of approach our team and know the details. Once again, thank you all. Have a good night. Take care. God bless.